Hey, good day and good evening, everyone. It's so good to see you all here back at IVF Webinars, and I'm happy that you decided to spend this evening with us. Before we will start, please give me a sign in the chat section that you can all hear me loud and clear, and just as I know that everything is fine, we will then start. Yes, and thank you for the feedback. Hi, Frank, and hi, everybody who is joining us today. I'm Sophie, and I'm your host today. Welcome to IVF Webinars by Egg Donation Friends. We are here every week to link you, patients, with best fertility experts from all over the world. All our IVF webinars are recorded, and it's just a vast source of IVF knowledge, and it's all available for you on our website at eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, Fertility Clinics Abroad, and Donor Conception Network. And tonight we are here together with Dr. Laura García, Medical Director at Clínica Tambre. So we say good evening to Madrid. Hola, Madrid. Hola, Dr. Laura.
Hello, good night, everybody.
Good night, good evening. It's our first IVF webinar with Clínica Tambre this year, but definitely not the last one. And for the good start, Clínica Tambre was rewarded by us as IVF patient supporter. This is a recognition that we give to all the clinics and IVF experts who share their knowledge with patients and provide them with answers to the most crucial questions. And actually, the main question of this evening is what to do next after failed IVF. And Dr. Garcia is the best person to answer this question, as she specializes in treating patients who have had previous IVF failures or who respond poorly to hormonal or IVF treatment. The presentation will take around 30 minutes, and next we will start the Q&A session, so please get your questions ready and type those questions in the chat section starting even from now. And now, straight back to Dr. Laura. Are you ready? Can we start IVF webinars tonight?
Yes, of course. Thank you, Sophie.
Yes, so let's do this.
Okay, so thanks for your time. As Sophie said, I'm Dr. Laura. I'm an expertise in reproductive treatments, and today I will speak about my IVF cycle failed, what to do next. This presentation will cover 3 parts. The first part is the definition and types of IVF. The second part is the most frequent and causes of unsuccessful treatment. And the third part is what are the potential solutions for your case. Let's start with the definition and types of IVF. So what is an IVF? It is a reproductive treatment that creates embryos in the laboratory to maximize chances of implantation. There are different types of an IVF. It could be own eggs and partner's sperm. It could be an IVF with own eggs and donor's sperm. It could be egg donation with either partner's or donor's sperm, or even it could be a ROPE method lesbian couple. Every IVF could be carried out with normal IVF in the laboratory, which means that the egg will be mixed with a lot of spermatozoa, and the best spermatozoa naturally will fertilize the egg. Or it could be done with ICSI procedure. The ICSI procedure is the intracytoplasmatic sperm injection, which means that the biologist is going to select the best spermatozoa, either from a donor or from your partner, to fertilize your egg directly. The process of an IVF starts with the ovarian stimulation. If you are the one doing the IVF, you will start from day 2 of your period with a hormonal treatment. It takes around 10 to 12 days, and you also will do many scans to check the development of the follicles. Of course, if it is an egg donor, this process will take place with the donor and not with you. The second part is the egg retrieval. This is a process carried out with sedation to obtain eggs through a vaginal extraction. The same day of the egg retrieval, the sperm is necessary in a frozen or fresh sample, and we will select the best spermatozoa of your sample to do the IVF or ICSI procedure. So the fertilization takes place the same day of the egg retrieval, and usually in Clínica Tambre we do recommend ICSI procedure mainly for cases of implantation failure. Then we will do the embryo culture, so it means that embryos are kept in our incubators until the blastocyst stage, so day 5. And the last part of the IVF is the transfer. It is carried out under a monitoring scan, and if there are good quality remaining embryos, of course we will freeze them for following transfers. So if the IVF is done with egg donation, we will take an egg donor less than 30 years and without reproductive problems. We will confirm with psychological, medical, and genetical tests that everything is all right and there are no problems for using that eggs. Of course, this is absolutely anonymous, so you will only know the age and the blood type of your donor, and the selection is done regarding your physical characteristics. And that woman, the donor, is the one doing ovarian stimulation and egg retrieval. You, as a recipient, will do the synchronization of your cycle with the donor. You will prepare your endometrium with oral tablets or patches, and we will do the embryo transfer to you. And of course, you will be the pregnant and the real mother. What's the ROPA method? So this is a process that is for lesbian couples that wants both to participate in the maternity. So there is the donor and the recipient part. The donor is the youngest, ideally, if less than 40 years better, is the one doing ovarian stimulation and egg retrieval, and is the one transmitting the genetics. Whereas the other woman, the recipient, is the one doing the endometrium preparation, doing the embryo transfer, and is the one carrying the pregnancy. And of course, this method allows the shared motherhood for lesbian couples that wants to participate both in the pregnancy. The second part of this presentation is the most frequent causes of unsuccessful treatment of IVF. So we need to remember that the 50% of unsuccessful IVF is due to embryo abnormality. But of course, there are 3 main reasons. One is embryo abnormality that could come because of a poor ovarian response and no embryos obtained, because of a poor egg quality, because of a male factor of your partner, because of a poor embryo morphology or transfers done on day 2 or 3, or because of chromosomical disorders in the embryo. The second part of possible causes of implantation failure is due to uterus, so uterine abnormalities, endometrial receptivity. And the third part is mainly due to coagulation and immunological disorders. So all what needs to do with the blood test and all the vitamins and all that is necessary for the implantation and the ongoing pregnancy. So let's start with the third part of this presentation, which is what are the potential solutions for your case. So mainly in this part, we will review all these aspects. So if the problem is a male factor, what to do, how we can improve your sperm or use sperm donation. If the problem is mainly your eggs, what to do for improving quality, or even if you need to go for egg donation, to use blastocyst culture 100%, to use PGS as well, endometrial tests such as ERA, endometrial hysteroscopy, and what are the immunological and coagulation tests that could be done to improve the next transfer. So let's start with the first part, with the first possible problem, which is the male factor. So some males are having normal parameters of sperm or even abnormality parameters, but we need to do specific tests such as COMET, which is to select fragmentation. We also have the possibility to do not only simple but also double fragmentation with this test that is called COMET. We can also check the chromosperm test in the sperm, will allows us to confirm if the chromosomes are balanced in your sperm or not, and also a FISH to confirm if all the chromosomes in your sperm are absolutely normal. Depending on the abnormalities and on the results on this test, we can use different techniques for fertilization to improve your cycle, such as chip fertile, which is mainly recommended for males having the double fragmentation high, the sperms low, which is recommended if the simple fragmentation is very high, or even max if apoptosis is more than the normality rate. If the problem are the eggs, we have different options. We can try to do another round of IVF with your own eggs, or we can go for egg donation. If another round of IVF is recommended, we can use melatonin, which is a very potent antioxidant that will improve your quality in your eggs. We can change type of stimulation to try to have more eggs or better quality. We can do a dual trigger, a dual shot of your ovulation to try to maximize the number of mature eggs if the percentage of mature eggs was less than 50% in the previous cycles. Or we can go for dual stimulation, which means to do 2 rounds of IVF to stimulation in the same month in order to have more eggs and maximize the number of embryos in total. If we go for egg donation, the recommendation is to go for a fertility proven donor. Study if immunological selection is necessary, and always, as I said before, do the blastocyst transfer, so the stage of day 5. So what is the blastocyst culture? We really need to avoid day 2 or day 3 transfers because we know that 50% of human embryos cease development on day 3. It really maximizes the pregnancy rates, and it is a better dialogue of embryo and endometrium. Because blastocyst is a very potent embryo, it's a very important it's very advanced embryo, and it really improves the implantation, and it really helps us to study if the embryo is good or not, because we can select, we can classify better, because we can see how expanded is that blastocyst. We can study the trophoectoderm, we can study the inner cell mass, so we really know more of blastocysts than day 2 or day 3 embryos. We always recommend to use time-lapse incubator, no matter if you're going with your own IVF or with egg donation, because we can have a higher rate of blastocysts. What is time-lapse incubator? It is an uninterrupted culture, so it's a very modern incubator that has a real-time image recording, monitoring an embryo development, because it has the microscope in that incubator, and it avoids the embryos to be removed every day and confirm in external microscope what is the development. It really maintains constant factors such as temperature, oxygen, light exposure. So it really improves the chances of have more blastocysts and to really have the good qualities ones. What about PGS? So if you're having previous implantation failure, it's very important to confirm if both karyotypes of you and your partner are normal before starting another round. And also it's very important to select only chromosomally normal embryos and avoid that embryos that could lead to implantation failure again or miscarriage. So it really increases the chances of a healthy baby by reducing the risk of miscarriage and increasing the chance of pregnancy per transfer. And it really reduces the duration of treatments and number of cycles it takes to achieve pregnancy. And what is the PGS? It is a process done in the stage of the blastocyst, and we are doing a little hole in the external part of the embryo with a laser, and we're removing some cells and studying the genetical condition of that cells to confirm if they are normal or not. Another part that is very important to confirm is endometrial receptivity, because we know that around 30% of patients have changes in the window of implantation. So they could be pro-receptive or post-receptive. So it means that they don't need to have the traditional 5 days of progesterone before the embryo transfer. So perhaps they need only 4 or they need more than 5 days of progesterone. So it is carried out with a biopsy, and we will confirm the endometrium receptivity in a prior cycle. It means that we're going to reproduce like a treatment for embryo transfer, but instead of doing the embryo transfer, we will take a little sample in the consultation room with a biopsy, and this is the error test. Also, there is the need of exclude endometritis infection because it could be one of the causes why good embryos are not implanting, and this is called the ALICE test, and it's also a biopsy. And also, the new evidence is recommending to study your microbiome, so studying the microbiome in your uterus, and this is also done with a biopsy, and it's called EMMA test. So the endometrio is a test that is including ERA, ALICE, and EMMA, and it's very important to have this test before another round of IVF because we will exclude there are no endometrial problems, and also very important to remember, confirm always progesterone level before embryo transfer. Also, it could be a problem because of uterine abnormalities. So it's really necessary to exclude uterine malformations that couldn't be regarded with a normal scan. So we will recommend to introduce a camera inside the room to confirm there are no septums, there are no malformations such as double uterus, or there are no pathological conditions such as polyps or fibroids that need to be removed. So the hysteroscopy can be done with sedation or in the consultation room, and it is introducing a camera to view the direct uterine cavity. Also, we are recommending, depending on the cases, to do a 3D scan or an RM to confirm if adenomyosis is present or not, and if a particular pretreatment is necessary before the embryo transfer. So the last part, as I said, is coagulation and immunological disorders. What about coagulation disorders? So we know there are women having potential problem with their blood, such as problems such as thrombophilia, antiphospholipid syndromes, homocysteine, or other conditions that potentially will benefit if they are doing treatments such as heparin or acetylsalicylic to make not that fluid their blood. And also, this kind of treatments will modulate coagulation and also improve implantation. Regarding the immunological disorders, this is a very particular part of the implantation failure, and it is necessary to study something such as the thyroid test because it really participates during the implantation. So we need to confirm in a blood test how is the TSH level and if antibodies against TSH are present or not, to check if we need to pre-treatment with thyroid hormones. Also to check some vitamins such as vitamin D, vitamin B, folic acid. Sometimes we're also studying the NK cells to confirm if your immunological system is affecting negatively to the implantation process. We're also confirming if you have a type of celiac disease that you've never been aware about, but you have this problem, so you need to have no gluten in your diet. And we will also confirm the CARE and HLA system to know if you have a negative prognosis and if some pretreatment or immunological selection of the donor is necessary. So what kind of coadjuvant treatments we can use for immunological disorders? We can use corticoids, we can use intralipids, we can use immunoglobulins, and it is going to be studied by our doctors, but expertise in immunology, and depending on the results and your case, we will give you the exact protocol to follow before the embryo transfer. And also, it is very, very important to remember the body mass index needs to be in the normal range, because if you are lower than the normality or above the normality, the implantation success rate is going to be lower. So thanks a lot for your time. I hoped you have had a good time with this webinar, and I'm here to respond all your questions.
Yes, and thank you, Dr. Laura, indeed, for a very informative presentation. And of course, we have some questions already on the list, but if anybody is waiting until now to ask a question, feel free to type your questions in the chat section. And as I said, we will take the first question already now. Could you please explain how is the fertile chip working?
Yes, of course. So a man that is having a very high fragmentation in the double brain of the sperm needs to take some pretreatment with curcuma in order to decrease that fragmentation. But usually the normality is not achieved. That would be less than 60%. So then the day of the fertilization of the eggs, we need a fresh sample, and then with this specific technique, the biologists will exclude the sperm that are very high fragmented, and we will only confirm and work with the normal ones.
Thank you for the question and as well for your answer. We will now take a look on the next one. What kind of possibilities are there to increase the eggs in a stimulation?
So of course it really depends on your ovarian reserve, because if you have had your last IVF round with the maximum dosage of gonadotropins, we are not sure if we could increase the number of eggs, but usually we recommend to use contraceptive pill to synchronize all the follicles, and then we do recommend, depending on the case, to go with 300 units of gonadotropins in order to maximize the response of the follicles. And the day of the shot of the trigger, we recommend to use not only one but also 2 injections, so decapeptyl and Ovitrel, beta HCG, to maximize the response of mature eggs.
Perfect. Thank you for your explanation. And of course, we have the next one. So we will now take a look on this one. I was also suggested KIR plus HLA test with my egg donation treatment. Could you please explain this?
Yes, so KIR is a part of a receptor in our cells that needs to be done before another round of embryo transfer, because if you have had an implantation failure, we need to confirm if you have a negative prognosis KIR, such as a KIR AA, because then we really need to select a donor that would have an HLA system C1C1 to maximize the possibilities of ongoing pregnancy. So it really depends on the result of the KIR if we need to select specifically the donor or do pretreatment in case of own eggs.
Great, thank you for your answer and of course for the question. And the next one waiting for you already is this question. Does using a double trigger injection, the HCG, have any positive effect on egg collection?
So usually the double trigger, it's mainly focused for the maturity of the eggs. So usually if you're having less than 50% of metaphase 2 of mature eggs, it's really indicated. But usually if we're having low recuperation, we also use it to try to maximize the egg retrieval number of eggs.
Thank you again. The next question will be this one. And is it true that after 5 days after fertilization, it can be said how the quality of the blastocyst is?
It's not true. With the blastocyst stage, we can really confirm if the blastocyst is good or not. So we have the first a number of the blastocysts. So the higher the number is, the better for the blastocyst. The second, we will have 2 letters. So the best is letter A. This is the best quality for blastocyst, but also letter B is good. So for instance, a blastocyst 4AA, it's a very good blastocyst, whereas a blastocyst 1cc or a blastocyst 2cc, it's very good, bad quality.
Perfect, thank you. And of course, we will jump to the next question, which is asked already. And this question is this one. What is endometrial biopsy and is it recommended for failed embryo donation?
So yes, endometrial biopsy is a process that is such as a smear test, but instead of focusing on the cervix, we're going to take a sample from the internal womb, from the uterus. Okay, so it's not necessary to go for sedation. It's not a surgical procedure. Okay, it's a routine in our consultation, and it is highly recommended for failed transfers.
And thank you again for explaining this to us as well. The next question we have is this one. What do you recommend for someone with MTFHR?
So depending on the abnormality of MTFHR and also depending on other parameters, we would only recommend high dosage of folic acid, particular folic acid and different dosage. But depending on the abnormality and other parameters, it could be also heparin treatment.
Again, thank you for your answer and for the question and questions which are still coming up. And the next is this one. What do you think of tacrolimus 4 milligrams per day plus 20 milligrams prednisona per day plus lenograstim?
So it's really a very high dosage of immunological treatment. So it's very, very important to review with an immunological doctor if all this is necessary or not, because we know that some women are having a lot of immunological pretreatment and it is negatively affecting the implantation. So in my opinion, this is really a lot. So it really needs to have a deep study to confirm if all this is necessary or not.
Perfect. And thank you for this one as well. And we will take a closer look on the next one. Is it really necessary to proceed with fresh sample with fertile chip? We cannot leave sample and freeze it at clinic. Is that recommendation by procedure?
Yes, it's really necessary when we are using fertile chip to do with fresh sample because it's not working with frozen.
Perfect, and thank you for your sharp answer to this question as well. The next one for you is this. Will fibroids removal improve chances of pregnancy?
So it's a very good question. Fibroids, we know, are not positive for implantation. So all women having fibroids have less chances to implant. But for the indication of surgery or not, it's very, very important to know what kind of fibroids in terms of location and also in terms of the measurement of that fibroids to confirm if it is necessary and if we will have benefits of the surgery, or if by contrast it is not necessary and can minimize the implantation.
Yes, and thank you for this one as well. And the next question on the list is this one. Is there a way to increase egg quantity if you have low ovarian reserve?
So very good question again, and thank you, Ad. Unfortunately, we cannot change your ovarian reserve. What we can only do is change your ovarian response. So we cannot do any treatment to increase your quantity. What we can try is to focus on a better response on yourself.
Yes, and we, of course, can take a look on the next question. And this question will be this one. I'll be using an egg donor and surrogate along with everything you spoke about. Is there anything that I really should be on the lookout for to have success this 11th time we do an IVF cycle?
So I'm sorry, Angela, for all your previous failures, but probably if you're going with a donor, I would recommend to use a fertility proven donor. And if you're going to surrogate, probably you don't need all these, but of course I will recommend the PGS. I will recommend the blastocyst, and to confirm the sperm it's absolutely normal before going for that round.
Thank you for clarifying this for us as well. And let's jump to the next question. Both me and my partner have done a karyotype test. Both came back normal. I'm having a frozen embryo transfer done next week. Will I need to do any further testing done during pregnancy?
So if you're both having a normal karyotype, it means that you don't have additional risk for abnormality in the embryos. But then during the pregnancy, of course, it's really necessary to confirm if the embryo is normal. So it is necessary to not only do scans, but also study the risk of Down syndrome, or even doing genetical tests to confirm that this is normal.
Yes, and thank you again for this question and your answer to this one as well. The next question will be this one. What is the optimal level of progesterone on the day of transfer to help implantation? What if it's too low or too high on this day?
Very good question, Anna Victoria. Thank you for adding this information. So progesterone needs to be confirmed before embryo transfer, mainly if you're doing progesterone vaginally. Whereas if you're doing subcutaneous injections 2 times per day, this is not necessary. So the recommended level is to have more than 10 or more than 11 nanograms milliliter. So it's not a problem if it is higher than this. The only problem is if it is lower. So then the recommendation is to test the progesterone the day before the embryo transfer, and if it is lower than this level, to add injections of subcutaneous progesterone.
Thank you again for the question and, of course, for your answer. We have a question which is connected to KIR and HLA, but maybe you can add anything on that. If doing donor egg plus donor sperm and failed one time, does it also apply KIR and HLA test?
Yes, sure. If you're having many rounds of embryo transfers of double donation, it's necessary to do KIR to study if the selection of donors are necessary or not. Not only with one previous failure, but if you're having 2 or 3 rounds of embryo transfer and you need to go for another round with another donor, then yes, it's necessary to know if we need to do immunological selection or not.
Thank you again for sharing this answer with us and for sharing the question, of course, as well. And the next one we will answer will be this one. What test would you recommend before a frozen transfer of day 5 embryo after failed fresh cycle?
So if you're having a fresh cycle, only one, and then you're going directly to a frozen, the recommendation is to check the window of implantation, so ERA test or endometrial. And if by contrast, if you're having more failures, then all coagulation, immunological, and uterine tests are necessary to exclude any reasons that could minimize the risk of implantation.
Thank you again for sharing and explaining this to us as well. Now we will have a much more specific question, and if it's impossible for you to answer, which is obvious from one point, remember that we will forward everything to Clínica Tambre tomorrow. So if you would like to add or ask any additional questions, you can do that as well, contacting us directly. I will put an email address in the chat section just in a second, but first I will display the question, which is really long, but I try to read that, and yeah, if you can summarize it somehow, it would be great. I am 44 years old, had 9 rounds of own egg IVF with additional embryo transfers with the frozen embryos with 3 different clinics. Always had very good results and excellent good quality embryos. The third cycle worked, however, had missed miscarriage at 10 weeks. I have now moved to donor egg, own sperm. We froze all embryos, 6 all are excellent, good quality. I have had 2 embryo transfers from the donor eggs and own cycle with 1 embryo each time, however, no sign of implantation. I've had in the past hysteroscopy 2 years ago and 3D aquascan 2 months before transfer, which showed nothing. I've had basic immune test and partner sperm, including DNA fragmentation, and all good. My clinic in Greece are suggesting another hysteroscopy before a further frozen embryo transfer. However, I don't know if this is necessary, or are there any other tests I should have?
So if hysteroscopy was normal 2 years ago and in the scan there are no abnormalities, I think it's not really necessary. By contrast, I will focus more on endometrial receptivity, and also I will focus on hematological and immunological tests to see if we need a pretreatment to maximize the possibilities of implantation.
Thank you for the question, of course, and for your answer. And the next one, which is quite similar, but let's take a look. At 47, 48 years old, free IVF with own eggs, 2 embryos each time transfer, all failed. Now 41, 6 years old, 2 frozen embryo transfer with donor eggs, 1 blastocyst, good quality transferred, both transfers failed. No PGS era test, no other issues than the age. Endometrium trilaminar 0.10, 0.11 millimeters. Progesterone at transfer 23 nanograms per liter, and on beta day 8 nanograms per liter. Treatment with vitamins ED, folate, zinc, selenium, aspirin baby. MTHFR and PEI mutations, omega-3. We still have 2 more embryos, day 5 and 1 day 6 left. I know that PGS is not a solution now, but according to this, what should I do next? I don't want to do another transfer without of change something. Thank you very much for all this information.
So, Anna Victoria, I definitely would recommend going for endometrial tests, so not only ERA, but also the others, Alice and Emma, so to confirm if receptivity and everything internal is okay, and also to study immunological conditions, because with 2 frozen embryo transfer from egg donation, we really need to know where are your problems and what we can do to improve your chances. By contrast, PGS is not recommended when embryos are already created, but if by contrast you should do in another moment another round of egg donation, then yes, PGS will be indicated, but not now, as long as embryos are already created.
Great, thank you a lot for the question and for your answer as well. We will take a look on the next question, the shorter one now. What happens to embryo if it doesn't implant?
So they are going out with menstruation, so it's exactly the same as when with a natural cycle. When we are having the bleeding of the menstruation, the endometrium and all the cells are removed.
Perfect, thank you for answering this question as well. And the next one is, the egg donor was selected with the same HLA. There was a decrease of number of NK cells. Is it necessary? The prescribed tacrolimus 4 milligrams per day plus prednisona 20 milligrams per day, lenograstin.
So it really depends in the NK, but if the selection of the donor was done and the NK was in the normal range, I would say it's not that necessary to do all this pretreatment, especially with all these 3 medication.
Yes, and again, huge thank you for your explanation to this one. And we have still some questions to go, so straight to the next one. Have you heard matrix test? Is it necessary or important before embryo transfer? Donor egg plus donor sperm.
Yeah, so matrix test, if it's the one that I'm thinking about, it's another kind of receptivity endometrium test. So also it is recommended, such as ERA endometrio, if you're having a story of implantation failure, to confirm there is any problem in your endometrium.
Yes, and thank you indeed for this one. The next one for you will be this one. What is the average number of IVF attempts before success?
So it really depends on the age, if we're going for own eggs or if we're going for egg donation. So it really depends on each case. If we're going for egg donation in my clinic, we have 70% of success rates with the first attempt. So normally in the first or the second, maximum third embryo transfer, we should achieve ongoing pregnancy.
Yes, and again, thank you for the answer to this question. We indeed have some questions to go, so this will be the next one. Can you do all these tests at one time if required if traveling from UK? I have had 9 failed transfers, 6 with own eggs and 3 with donor eggs, not proven fertility or immune tested. All followed the same protocol, so I'm anxious about further treatment. But with all these options, it would appear it would be more possible for success. What are the success rates for pregnancy in 44 plus age group at your clinic? And many thanks.
So thank you, Ali, for your question. Yes, we have lots of patients coming from the UK with implantation failure, and in the first consultation, in the first appointment, we're doing in one day all the tests that are necessary. And when we're going for egg donation, your age is not important. So again, it would be around 65 to 70% per embryo transfer, your success rates. So depending on the number of cumulative embryo transfers, it could achieve the 95%.
Thank you for sharing this success rates. And yes, we have the next question. My doctor recommends Clexane injection and Adira tablets before frozen embryo transfer. Is this necessary because I don't have a history of blood clotting?
So it really depends on what kind of history you're having, but my recommendation is not to use heparin and Adiro if you are not having abnormalities in your tests. By contrast, I know there are other colleagues that only because of the history of the patient is introducing Clexane and Adira to maximize chances. But our recommendation is to do all the tests and only to do specific treatment if necessary.
Thank you a lot. And now the question appears very specific about your clinic. So let's take a look. What is the name of your clinic and what's the average price for own egg with sperm donation?
So the name of our clinic is Clínica Tambre. It's based in Madrid, and it depends on the package you want to take for egg donation, but we start with 5,900 euros.
Yes, great. And thank you for the answer to this question as well. Someone is typing, and I believe I had actually displayed and published all the questions we had so far. So in the meantime, I will show you some shout outs. Thank you very much again for all this information and for the answers. Indeed, thank you very much. We can actually continue with those. Thank you to you both. But in the meantime, we have also 2 more questions coming up. So, Dr. Laura, can we take those as well?
Sure, no problem.
Yes, and great to hear that. And this will be the next question for you then. I have heard from 3 different doctors here in Switzerland that fibroids have nothing to do with IVF success. Can you add some light on this? And thanks.
So, as I said before, Joan, it really depends on the location of the fibroids. So, we know if you're having an implantation failure story and you're having fibroids, it's very important to study if that fibroids needs to be removed to maximize your chances. So, if fibroids are affecting the endometrium, so our submucous fibroids, it's 100% necessary to be removed. If they are completely external, then it is not necessary. And in the meanwhile, in the medium, if we have intramural fibroids, it really depends on the measure of that fibroid to decide if surgery is necessary or not.
Perfect, thank you. And the next one is then this one. I missed what you said about adenomyosis. Do you treat this? And maybe you can add anything about it.
Yes, thank you, Ed. So yes, we treat adenomyosis. We know it's very difficult to know if a patient is having adenomyosis or not. And it is recommended if you're having adenomyosis and a story of implantation failure to do specific pretreatment, medical pretreatment with 3 months of agonists to minimize the activity of adenomyosis and try to reduce the risk of miscarriage and maximize implantation rates.
Perfect. And again, a huge thank you for those who are asking and for those who answers the question, Dr. Laura, to you directly. And now let's take a look at the next question. What number of eggs is satisfactory to obtain after a stimulation? I have a daughter after an IVF 7 years ago. After that, I had 10 IVFs with more than 15 eggs obtained, good quality embryos, but not good enough. So no implantation. I had to take 2 years break due to breast cancer. Today I am 44 and my doctors say it is okay to make 1 or 2 last attempts. I suppose to try with own eggs will give basically no chances. What would be your suggestion?
So thank you, Yvonne, for your question, and sorry to hear you had a breast cancer, but very happy to know you're ready for another round. And yes, with 44 years, we cannot say it's 0% of pregnancy, but it's less than 3%. So with your story, I definitely will go with egg donation to maximize your chances. Generally speaking, when we are more than 43, we're always recommending 100% egg donation.
Yes, and thank you for your answer, and as well, thank you for sharing your personal story with us. And we have the next question. So we will take a closer look at this one. I'm new to IVF. What tests can I and my partner do? We are looking to do a tandem cycle soon.
So the tests that are necessary before going a round of IVF is to do the general tests such as ovarian reserve, AMH, scan, and also to do all other necessary tests before starting the IVF. If everything is normal, then the IVF can start. But if there is any abnormality, we will recommend you to do any specific pretreatment.
Yes, perfect. Thank you for explanation to this question as well. We have the next one. In my case, the doctors say a surgery cannot help with taking out the fibroids due to too many. Is there another possibility than a usual surgery? Thanks a lot for your answer.
So for fibroids, it's very important to share the information with a very expertise doctor in fibroids to really understand what is necessary in your case, if we need medical treatment or if we need surgical treatment. It really depends on that case, and I will be very happy to help you.
We are slowly moving till the end of Q&A session, but questions are still coming up. So let's take the next one. Hi there. After failed donor embryo transfer, I am now scheduled for an open myomectomy to remove a fibroid that had started to grow into the womb cavity. How long would you recommend I wait after surgery before doing IVF?
So normally, if you're going a surgery to remove a fibroid, it's around 2 months, 3 months maximum. But if it is not very big, sometimes we can do it the next month. So usually, if it is a hysteroscopy process, it takes around 1 to 3 months for the embryo transfer.
Perfect, and thank you for your straight answer to this one. And the next question is, I think, interesting one also. So, what questions should one ask on the day of frozen embryo transfer about the embryos? Mine is scheduled for next week in Spain, and it's my first time.
So in my clinic, patient does not need to ask anything, and the biologist and the doctor is confirming how is the thawing and how is the quality of the blastocyst before doing the embryo transfer. So it's very important to confirm how is the process of the blastocyst thawing.
Yes, and great to hear that patients don't have to ask. They have the answers already delivered by all the team of Clínica Tambre. Okay, someone is typing, so we will take just a few seconds and see. In the meantime, we have a shout out. Thank you very much. And yes, thank you very much for your presentation at the beginning and now answering all the questions, which we have so many this evening. And one question appears, which is, it is a follow-up comment on the question which we have. Sorry, going back to my last question, my fibroids is 4 centimeters and I'm having open abdominal surgery. Will I have to wait longer after this?
Yes, if it is an abdominal surgery and if endometrium is opened, then we need to wait at least 6 months.
Okay, and still in the topic of fibroids, I have too many, and under the fibroids there are already the next one growing. They grow in the uterus. I had the surgery already 4 times in a specialized clinic. So this is like quite, let's say, common issue we may find.
Yes. So we will be very happy to confirm that there are no other reasons apart from the fibroids and to confirm that embryo is good quality and everything is done in parallel, not only the fibroids.
Yes, and we have one more follow-up comment. So it said my uterus is 8 times bigger than a usual one. Does that help?
It's not really helping. It's really decreasing your chances if you're having such a huge uterus, and it's very important to confirm if something is necessary before the next embryo transfer.
Thank you for this. All the questions and for all your answer. Thank you very much. We will be now slowly finishing, so thank you. And one more time, very informative webinar. Many thanks. In the meantime, still somebody is writing, so we will just take a second. But yes, I think that this will be as well shout out. So thanks a lot. And indeed, it was a pleasure to have you here, Dr. Laura, and thank you one more time for all the knowledge and information you shared with us this evening. So it was really helpful and informative for everybody who was with us this evening. I would like to thank you, everybody who was joining us this evening, for your time as well. And of course, this IVF webinar will be available on our website tomorrow. The recording from today will be as well available on our YouTube channel. And all I can do is to encourage you to stay in touch with us by following us on Facebook or on Instagram. As well, you can follow Clínica Tambre, who has as well great content on their social media channels. So feel free to do that. Dr. Laura, if you would like to add anything, make any final comment, you can do that now. And yeah.
Just thanks to everyone for hearing and spending the time with us. And please choose a very good clinic, mainly if you're having implantation failure, to maximize your chances and not only doing embryos and embryo transfers without changing anything.
Yes, and thank you one more time for being here tonight with us. Thank you, Dr. Laura, and thank you, Clínica Tambre. Till the next time, and for today, good night, good night sleep, or good day wherever you are, because we have probably somewhere from the other part of our globe. So hopefully till the next time, bye.
Thank you.